how long it takes. If we take a break, I'll give you all a chance to ask questions, and then I can address them when we get back, when we return. So let's get started. Drugs. So we're going to be talking about the GI system. We're going to talk about one of the most important, the most common gastrointestinal conditions, and it's GERD, gastroesophageal reflux disease. Gastroesophageal reflux disease represents several different kinds of stomach issues. It can just be anything from heartburn, or it can be acid indigestion. It can be something that's structural, but it all falls under the category of gastroesophageal. So G, gastro, E, esophageal, reflux, R, disease, GERD. Peptic disease, that's slower in the stomach. Ulcerative colitis. So ulcerative, that's just exactly what's an ulcer. You think of an ulcer, that's when you have an erosion in the membrane of the top layer of the skin lining. Colitis, this is in the colon. About Crohn's disease, we're going to talk about gallstones, diarrhea, constipation, and related. So we have constipation that's caused from there's certain physiological causes, such as your diet. Like cheese can cause constipation, inability, low motility. If somebody's bedridden or doesn't have much physical exertion or exercise, then it's going to inhibit your body's ability to function properly. If you think about it, when you stand upright, in addition to our body's muscles, the peristalsis that moves our digestion process along, we have gravity that helps. What's interesting is if you happen to know somebody in the veterinarian program, when you learn about giving dogs and cats medicine, or when they eat and how they metabolize things, guess what? Their digestive system is, would it be horizontal or vertical? It's horizontal. So they don't have that advantage of gravity. That's one reason it's so important that they have activity. But with human beings, if somebody's laying flat in bed or they're not moving, they lose that one major advantage of just gravity forcing along the peristalsis or moving up. We're going to talk about nausea and vomiting. Hepatitis. What's hepatitis? Hepatitis, this is a viral infection or inflammation in the liver. We're going to talk about the different kinds. And then finally, we're going to talk about complementary and alternative therapies. Now, most people, when you see complementary, they'd be saying like, oh, Dr. Purrier, I like your haircut, even though you did it with dog clippers. No, I did. No, complementary, that's just a word. The word complement is another word for supplement. It's something that's going to supplement or be used in addition to, something to help complement. Alternative therapy. So when you see CAM, complementary alternative medications, that's referring to the medicines that would be considered herbs and supplements or extracts. And what's interesting, you're going to discover. So when you walk into a pharmacy, you're going to have the vitamin section, then there's going to be a section of the herbs, supplements, and the complementary alternative therapies. There are a lot of complementary alternative therapies that are as effective as drugs. There's one medication is St. John's wort. It's just an extract from a plant, and in Europe, it's been demonstrated to be as effective as the selective serotonin reuptake inhibitors. So that means it's been demonstrated to be as effective as the drug Prozac. Most of y'all have heard of Prozac. With the digestive system, you're going to, for nausea and vomiting, you're going to hear me talk about ginger. There's ginger root. They take an extract. It comes in all kinds of forms. There's lozenges. There's chewable, like gummy bears. There's tablets. But ginger, it's got a soothing. It soothes acid indigestion. It soothes nausea, and it has been demonstrated to be as effective as many of the medications that are used for nausea and vomiting. One reason it's extremely valuable is that it's safe to take or use during pregnancy. But something else you're going to find, some of these complementary alternative medicines, they interact with drugs, and there can be some significant interactions. Most patients assume if you can just buy something over the counter, it's got to be harmless or safe. And that's not the case. Once again, only the pharmacist is able to discuss interactions and make recommendations. As a technician, though, your awareness, your knowledge that there is a concern, that's what empowers you to identify opportunities whenever the pharmacist does need to become involved. So the GI system is it's a continuous tube. It starts at the mouth. So it doesn't have a picture of lifts up here, but it goes from the mouth to pharynx, esophagus, stomach, small intestine, large intestine. So you see here we've got the stomach, you've got your colons, you've got the descending, the sigmoid. So we go through the small intestine to the large intestine, the rectum, and the anus. What is the main function of the GI system? It's to digest and absorb food, drugs, and fluids. In other words, so it's to enable nutrition to enter our body's bloodstream and to provide the nutrition and energy to our body. How though? Things have to be absorbed. And you guys know about the first pass effect, you know about drugs. Any drug, what is the first pass effect? We talked about this earlier, so I know everybody knows the answer. But any drug that's taken by mouth, anything that's taken orally, it's going to, if it's a tablet, capsule, or a liquid, whatever, it's going to have to convert to a solution, to a liquid form in the stomach. From the stomach, it's going to pass into the small intestine. The small intestine is where drug absorption takes place. So drugs are absorbed through the lining in the small intestine. And guess what? No matter what drug is, there's no exception. It's going to go into the hepatic portal. The hepatic portal is like a gigantic tuba. And so every drug they go in, and then it gets funneled in, but it's going to end up going through the liver, where it undergoes first pass metabolism. So it's going to be filtered before it even enters the bloodstream. So, but a critical factor for a drug that you take by mouth, for it to get into the body, it's got to be absorbed through the intestine. And so as somebody gets older, you have to take things into consideration. There's slowed digestion, digestive motility. There's scar tissue. If somebody has a stomach or a duodenal ulcer, and it heals, you're going to have scar tissue. And that scar tissue, it's going to be very hard for anything to be absorbed across that tissue. So there are factors you have to consider as somebody gets old as they age. But the primary function of the digestive system is to absorb food, drugs, and fluid. And then finally, excrete the metabolic waste. So what are the organs in the system? The salivary glands. If you're familiar with Pavlov and his dogs, they heard a bell ring and they knew they were going to get to eat. So they hear the bell ring, they start salivating. That's whenever you start having the fluid production in your mouth. That salivary liquid, when you salivate, you're actually creating enzymes that are the very first part of digesting food. So saliva contains enzymes that begin digesting sugars. Also, it lubricates foods to make swallowing easier. Now we got the pancreas. What's the pancreas? The pancreas produces enzymes that are necessary to digest carbohydrates, fats, and proteins. And there's a medical condition called cystic fibrosis. It's a condition of the exocrine system. And in that condition, a person's pancreas is unable to generate or create these enzymes. So a person born with cystic fibrosis has to use artificial, or they take them actually in a pharmacy. If you have a patient with cystic fibrosis, you're going to be dispensing amylase or lipase, and they're going to be taking it just for their entire lifetime. Pancreatic secretions decrease the acidity of stomach contents as they enter the small intestines. Something else you're going to learn with drugs, especially sustained release or controlled release drugs. One of the ways that we're able to control how and when a drug is released is by putting it in some kind of formulation that is sensitive to the pH, because we actually identify and know what the pH of the stomach is going to be. We know what the pH of the small intestine, and we know the changes in the pH as food is traveling through the intestines. So it's because of the pancreatic secretions that you decrease the acidity. And this is where a lot of the drugs that are sustained release start releasing medication. Then we have beta-2 cells in the pancreas, and stimulation of these beta-2 cells create insulin. We have to have insulin to break down our carbohydrates into energy that can be used. So where else do we have beta-2 cells? So beta-2 receptors. You've got beta-1 receptors in the heart. Beta-1, you've got one heart. You've got beta-2 in the lungs. How many lungs do most people have? They have 2. But you also have beta-2 cells in the pancreas, and stimulating these receptors triggers the production of insulin. Finally, the liver. The liver produces bile. Bile is stored in the gallbladder, and bile is necessary to absorb fats and cholesterol. You're going to find the liver, excuse me, the liver is where cholesterol is formed, and the liver plays the most significant role of any organ in our body as far as cholesterol level. So what is transit time? Transit time, if you think about a bus and you have a bus stop and when you get from station A to station B, that's your transit time. Transit, how long does it take to get from one point to the next? So in the terms of gastrointestinal, we're talking about bowel transit time. It's the time it takes for material to pass from the mouth to the anus. It's known as gastric motility. Gastric motility refers to gastric emptying. That's the step where the contents that are in your stomach are emptied and passed into the small intestines. One time I had a quiz and I asked, what is gastric emptying? And a student wrote, it's to fart or burp. I guess that's a release of gas, but that wasn't what I was looking for. Gastric emptying, you think it's the contents of the stomach. Contents of the stomach are emptied and passed to the small intestines. Remember, the small intestines, that's where drugs start being absorbed. It's not until they reach the small intestines that they're going to be absorbed and get into the bloodstream and exert their action. So if there's a number of reasons we'll talk about that interfere with gastric emptying. If you have slowed or decreased gastric emptying, whenever you would give a medication and you'd be expecting to see some results in a certain amount of time, then it's going to be delayed. Excuse me. So the content transit through small intestines and then finally the colon. What affects gastric motility? Peristalsis. So that's the autonomic smooth muscle contractions. So autonomic, that's the system. You're not having to think about it. Just like you breathe. When you fall asleep, you're not having to think. You're actually, your body's breathing for you. These muscles, your diaphragm, your heart, it's operating without you having to stop and think. Beat, heart, beat, heart. Well, the autonomic smooth muscles, you have muscles, bands of smooth muscles throughout your digestive system. And they contract, they constrict and relax and contract. So these contractions are, it's kind of like a snake, a boa constrictor, whenever it swallows something and it's got to force it to pass through its system so that it can digest. Well, that's what's happening inside of our body. We have muscarinic receptors on smooth muscle tissue throughout the digestive system. Gravity, remember I just mentioned gravity, and then physical activity. So guess what, when you're moving around, it's helping to stimulate your gastric motility. And it just makes it common sense if you think about it. If you're just laying down, or even if you're just seated, reclined, without moving, it's much harder, even with the internal muscles, even with the contractions, it's just not getting any assistance. And so physical activity, standing upright, the gravity, those are essential components in your gastric motility. And the ingested content. So certain things are going to go through your system faster than others, than drugs and or chemicals. And an example there would be milk of magnesium. Milk of magnesia, if you take a tiny amount, it's very effective as an antacid. But if you take a little bit more than a tiny amount, all of a sudden, it's like a laxative. And on the bottle, this is something I learned a long time ago as a pharmacist. It'll say, it may take up to 6 hours. Some people, it works in 15 or 20 minutes. And when it works, they might have like very liquid, watery diarrhea, just bouts of it every 10 or 15 minutes over several hours. So it's an example of the magnesium and that triggers rapid gastric motility. And then various medical conditions. So what happens if you speed up gastric motility? Well, you decrease the absorption of your medications. What does this mean? So if I take a medication and I'm anticipating a normal person's, like how long it's going to take to turn into a liquid in the stomach. Then how long it takes to go from the stomach into the small intestine. In the small intestine, it needs to remain there long enough to be absorbed through the membrane lining. If it gets moved too quickly, your body's not going to have a chance to have absorbed enough of the medication. So if you speed up that gastric motility, what's an example of speeding it up? Well, if you have diarrhea, if a person has diarrhea, when you have diarrhea, things are being removed out of your system significantly faster than ordinary. Now, slowing down, here's an example, constipation. But the main thing that you're going to see, especially in the elderly, it has to do with lack of activity, remaining either just sitting in an upright reclined position or even laying flat in a bed. You don't have that gravity. Gravity is a very, very essential component in a perfectly functioning physiologic gastric motility. So slowing it down, you end up increasing an absorption of the medications. So as you learn about the system, you'll understand the significance and how it affects the absorption of medications. What's the big deal about cholinergic and anticholinergic? So I'm going to give you it's an acronym, and it might seem like a little, like it's not a big deal. I'm saying anti-SLUD. What's anti-SLUD? SLUD stands for salivation, which is our mouth watering, lacrimation, that's tears, our eyes watering, urination, and defecation. So when you hear the word anticholinergic, I want you to automatically remember anti-SLUD. So if a drug's got anticholinergic side effects, that means it's going to cause a dry mouth, dry, irritated eyes. It's going to interfere with your ability to urinate. It's going to cause constipation. And if a drug has cholinergic properties, it does just the opposite. If it's cholinergic, you're going to have a blurry vision, a lot of watery eyes, and you're going to have faster than normal digestive processes like defecation. So ironically, like the very first day I had in pharmacy school, the very first thing written on the board, the first thing we learned was anti-SLUD. And we didn't understand it at the time. What's the big deal? What do we need to know about anticholinergic? But you're going to find out there's two elements. One, there are drugs that are anticholinergic, and they're used specifically because they're anticholinergic. We're specifically targeting cholinergic or muscarinic receptors, and we're using them specifically because they are an anticholinergic drug. Then we have drugs that are anticholinergic, and we use that to determine or to be prepared for the side effects to anticipate. So some drugs are used exclusively for their cholinergic or anticholinergic properties. Other drugs have cholinergic or anticholinergic side effects. By memorizing these effects, by memorizing anti-SLUD, the moment you know if a drug's anticholinergic or cholinergic, or if it has these properties, you're automatically going to know the main side effects. So remember, anti-SLUD, salivation. So salivation, that's your watering of your mouth. So a simple way to say it, you can't spit. Lacrimation. Lacrimation is your eye's ability to form tears. So anti-SLUD means you're not able to make your tears. You have dry eyes. And this causes difficulty seeing. So when you don't have enough moisture in your eyes, it can result in blurred vision. It interferes with urination. You have muscarinic receptors in your urinary bladder. And so when you have the anticholinergic activity, it's going to interfere with your bladder's ability for you to control that bladder, and it's going to make it more difficult to urinate. And then defecation, constipation. So guess what? Especially if anybody, you won't ever hear me say this, but this is something that I've seen students use to remember. You can't see, you can't spit, you can't pee, and you can figure out the rest. It's just one way to remember. It's a great big deal. You're going to understand with the more drugs, every single drug, whether it's cardiovascular, if it's respiratory, even some antibiotics, it's that if the moment you find out whether this drug has cholinergic side effects or anticholinergic properties, you automatically know these major effects to expect. So what's a prokinetic? a cholinergic drug. Prokinetic stimulates gastric motility. It helps move things along. We have one that's used, this is one of the most common drugs. I think it's number 26 in our top 200 drugs. If you work with long-term care or in a group with the nursing home or with elderly, you're going to find almost every patient that's elderly is using Reglan for one reason, especially if somebody's bedridden. The Reglan, it stimulates the receptors to stimulate the peristalsis, to stimulate the gastric emptying and gastric motility. Otherwise, you end up with all kinds of problems with constipation. It interferes with absorptions of medicine, a lot of problems. We used to have a drug called Propulsid. It was cisapride. It stimulated the cholinergic, or muscarinic is one of the types of cholinergic receptors in the lower esophagus and lower esophagus sphincter. So this turned out to be ideal when, with infants that are born, a lot of babies that are born, there's two different sphincters in the esophagus, and these sphincters, when you eat and you swallow, the sphincter closes so that you're not having acid erupt back up into your mouth or into the esophagus. But some babies, when they're born, that this sphincter is not fully developed. So a lot of times they used to misdiagnose it and call it colic. A baby would eat and then it would just cry and be miserable. But once they realized that it had to do with this poor development of the esophageal sphincter, they thought, well, Propulsid came out. They had a suspension. It was used in infants as little as 1 month of age. It worked like a miracle drug, and it just took off throughout the world. The only problem is Propulsid had effects on the heart rhythm, and it also had multiple interactions. It had interactions with antibiotics like erythromycin that were so severe, it resulted in deaths. And so anytime you have a medication and somebody dies, it's going to be reassessed just to evaluate if it's really worth. And because we already had Reglan and we have a few other options, Propulsid was removed from the market. Anticholinergic medications. So remember, I mentioned that we use some medications specifically because they're anticholinergic. Ventil is an example. Now, when you're working in your community pharmacy rotation, I hope each one of you gets to count out some Ventil tablets. It's my favorite color of blue turquoise that you'll ever see. They're beautiful. Ventil, it's an anticholinergic drug that relaxes the lining in the lower digestive system. It's especially beneficial for people when they eat, they'll experience cramping just because whether it has to do with some damage to the muscle tissue that's responsible for peristalsis, for any number of reasons, it works directly on muscarinic receptors and helps them to operate more efficiently, but it relieves cramping. So whenever people have abdominal spasms or abdominal cramping, if you happen to sit next to somebody and you're hearing their stomach just growl and grumble, well, this is something that would help give them relief. It's considered antispasmodic because it's helping to treat and prevent spasms. It slows GI motility. So you wouldn't use it if somebody has a diarrhea because it's not really going to stop or halt that. But what it does do is it slows down GI motility, especially when the GI motility is going faster than normal, just because the muscarinic receptors aren't working as well as they should, or the muscles in the peristaltic tissue are not working as efficiently as they should. Also, when people do have digestive system problems, you're going to find out it's not always just taking a pill that's the solution to a problem. Many times it's lifestyle modification and it's modification of diet. And so when a patient goes to the doctor and they're complaining about all these issues, there might be a medication like Ventil that's going to help relieve, help prevent the spasms. But then another element is to address any lifestyle issues. I'll just give you two examples. Smoking cigarettes. Smoking cigarettes, it's not just about what you're introducing into the lungs. You're also, you're introducing a lot of different chemicals, many different chemicals into your digestive system, and they're responsible for causing irritation and creating some problems. The same thing with alcohol. Alcohol is very damaging. It's harsh on the system. Um, when I worked at Walmart, I watched something, and it was one of the most incredible learning experiences of my life. There was this lawyer. He worked for Vincent Elkins, one of the top law firms in the nation. He was at the top of his game. He came in wearing a suit that cost more than I made a month. But just one day he comes in and he has all these medications, and I noticed he was seeing a gastroenterologist. And then just over a period of several weeks, he kept coming in, all kinds of different combinations of medications. And I could clearly tell there was something serious going on with his digestive system. And it appeared like maybe it was Crohn's, irritable bowel syndrome, something, or diarrhea related. But I watched him as he went on disability. He lost his job. And then he reached a point where his mom would come in with him, and she was charging his medications because he couldn't afford them. One day when he came in, this is back whenever you could ring up anything at the pharmacy, he brought this shopping cart, and he had 23-pound cans of Folgers because they were on sale. And when I was ringing them up for him, I said, well, this is going to last you quite a long time unless you're going to be giving these out to friends or and he goes, oh, this won't even last me maybe a week. And so immediately I'm thinking, okay, he's telling me he's going through this much coffee in a week. That sounds like it could have consequences. And so I just carefully asked him, I said, so have you ever talked to the doctor about drinking coffee? And he said, well, yeah, on the patient information form, I did put a check mark by the box that says you drink coffee. And I said, well, how much coffee do you drink in a day? And he goes, oh, just a couple of pots. Okay. And once again, you're going to learn it's very important. You're going to be in a position where somebody's going to come up, and just based on the prescriptions they hand you, it can be overwhelming. And you're just emotionally, your body's going to instinctively want to react. For example, you're going to know if somebody brings in a prescription, just looking at the prescription, you're going to know that they just had an abortion. Now, you're not in any position to judge anybody, and you're especially not going to react in any kind of way that would be offensive, or you're a professional, so you need to be prepared for that. And the same thing happened with this guy. I'm realizing things very quickly. I'm thinking, he's a lawyer, he's sharp. How could he not think there's going to be some kind of bizarre consequence from all this coffee he's drinking? So I had to be very careful in my reaction. I also wanted to be careful in how I was just asking him some questions. This is before HIPAA came out, but when he left, I called the doctor's office. And then guess what? Within the next 3 weeks, the next time he came in, he had a different set of medications. He looked an entirely different person. And he didn't even realize I had been involved, but he told me, you'll never believe what my doctor figured it out. I was drinking too much coffee. So anyhow, the food that you're introducing into your system, it plays a role. The food, the drinks, the alcohol, coffee. Dicyclamine, guess what? It's anticholinergic, and the properties, so of the anticholinergic, we've got the dry mouth, we've got the dry eyes, but it's most specifically its beneficial effects on the digestive system. Then we have transderm scope. Most of y'all are familiar with this. It's a little round patch. It looks like the little round Band-Aid, and you put it behind your ear. It's placed behind the ear for 72 hours. Now, it's approved, FDA approved indication was for motion sickness. So if somebody's going on a cruise, it's real common. If you're on a cruise, you'll notice a lot of people wearing just the little patch behind their ear. But it's also beneficial in nausea and vomiting. So what's important to know, transderm scope, it's the only medication used for nausea and vomiting that's available topically. You apply it behind the ear, a patch behind the ear for 72 hours. Whenever it's time to replace, you take it off, you put a new one on, and you just alternate sites. So its main indication was seasickness, but it's used for nausea and vomiting, and it's anticholinergic. Then we have, finally, we're going to talk about oxybutynin. Oxybutynin is anticholinergic. It comes available as a tablet called Ditropan, And ditropan, it was taken primarily if somebody had an overactive bladder. As you get older, you don't have the same muscular control of your bladder as you do when you're younger. This works specifically on the muscarinic receptors in the bladder, and it helps you to regain control over the bladder to prevent leakage. Because we have the fastest growing segment of our population is over 85 years old, people are living longer. As you live longer, well, things stop working as well as they did when you're younger. So it turns out, if you'll notice at Walgreens, anywhere, the adult diaper section for the pads and diapers, depends, it's just going to be a massive aisle just because it's something that's commonly used and commonly needed. This is an issue that affects everybody as they're getting older. Well, they went ahead, the FDA decided, you know what, a patient is capable of using a patch, an oxybutynin patch. You apply the patch and it helps control the urinary, prevent urinary leakage. When it first came out, the approval was indicated for women. It's more of an issue with women. With men, there's an additional consideration that has to do with the prostate. So that's just a secondary factor that has to be considered. But in particular for women, the Oxytrol patch, it's available over the counter. They apply a patch once a day, and it helps prevent the urinary leakage. So the esophageal sphincter in the stomach. If you notice right here, here's your stomach, and right here is the sphincter. So whenever you eat or drink, that sphincter, it opens to allow the liquid or the food into the stomach, but then it closes. Whenever it doesn't close properly, whether it's due to a weak or poorly developed sphincter, or if the sphincter's just been damaged, you can damage it. Somebody who, there was a man that was they have contests for people, see who can eat the most in the shortest amount of time. Well, if you're busy swallowing 300 hot dogs in 2 minutes, you're going to ultimately damage the sphincter. So the stomach's composed of multiple layers of smooth muscles. They're lined with glands. There's a mucosal coating due to prostaglandin E. Remember, guys, when we talk about non-steroidal pain medicines, they work by preventing arachidonic acid converts to cyclooxygenase. Cyclooxygenase is converted to 16 different prostaglandins. Non-steroidal drugs, they inhibit the arachidonic acid from converting to cyclooxygenase. Well, that works great to prevent inflammation, but a consequence, it prevents the body from making prostaglandin E. And you need prostaglandin E to protect your digestive system. That's a mucosal protective coating throughout your system. So that's one of the reasons that the non-steroidal drugs can cause ulcers or be irritating to the digestive system. You have parietal cells that secrete hydrochloric acid. Antacids. Antacids are an example of a drug. So whenever we look at what's the definition of a drug is anything that has an effect, a physiological effect on the body. Some drugs, they work by blocking receptors from being stimulated. Other drugs work because they are so similar to a naturally occurring receptor, they're able to trigger receptors in our body. We have some drugs that work because it's kind of like a bug poison. If we have an infection caused by a bacteria, we can take an antibiotic. The bacterial cell walls are vulnerable, and so the antibiotic kills by disrupting the cell wall. In the case of these antacids, it's basic chemistry. So those of y'all that had chemistry, whenever we've done some experiments, but you'll notice these are cations, and a cation is whenever you have an ion that's positively charged, like calcium is capital C, little a, +2. Same with magnesium. And these are going to bind with free, like hydrochloric acid is HCl. And so you're going to end up binding with the chloride and to disrupt or to decrease your acid production. So these work directly, it's just a simple chemical reaction with hydrochloric acid to neutralize the acid content in your stomach. Then we have histamine 2 receptors. So when we talk about what is Benadryl or diphenhydramine, it's an antihistamine. People that haven't ever been in pharmacy, been in class or as a pharmacy technician, if I say, what's an example of an antihistamine? Many people say, oh, Benadryl. They know you can take it for runny nose, water UTIs, or for an allergic reaction. Well, it was one of the first histamine 1 receptor blockers, or antihistamine, histamine 1 antagonist. Guess what? Then a few years later, they recognized we have additional histamine receptors. Well, we already named the first one histamine 1. So what do you think they named the second histamine receptors? Histamine 2 receptors. The histamine 2 receptors, they're on the skin and throughout the body, but they are predominantly in the digestive system. And so they, whenever you stimulate a histamine 2 receptor, it triggers acid production. So it was right when I finished pharmacy school. It was brand new. Somebody won a Peace Prize award. The histamine 2 receptor blockers came out, and there's a whole list of them, but they end in tidine, Tidines. So you're going to see on that chart that I posted in your resources page, you're going to see as you're doing your worksheets and going through. But when you see a drug that ends in tidine, it's an H2 antagonist. Now, how is it that it just so happens a bunch of generics are going to have a suffix that helps you identify what the drug family or class? It's because in the United States, there's a United States Adopted Name Committee that is responsible for naming all generic drugs. And so whenever there's a drug that is chemically similar in structure or is in the same class, they identify and create a prefix or suffix, and they're going to assign that to any drug that comes out that's in the same family class or molecular structure. And so in this case, any of the H2 antagonists that came out, they named them so that the suffix is Tidines. Then a little bit later on, so then the tidines were discovered in the mid-80s. The prazoles were discovered in 1990, and the prazoles, they work by blocking the proton pump. The proton pump in your parietal cells pumps out hydrochloric acid. So if you inhibit this proton pump, you're preventing the production of hydrochloric acid. When the proton pump inhibitors first came out, they were originally FDA approved to be used only for 2 weeks. Everybody was terrified. They thought, oh my, if you take a proton pump inhibitor, your body's not going to make any hydrochloric acid, and that's going to cause cancer and all kinds of problems. But the thing is, you make hydrochloric acid in many places, not just the stomach. So these proton pump inhibitors, they primarily target the parietal cells in the stomach, but you still have other sources that are creating hydrochloric acid. So even when somebody's taking a proton pump inhibitor, they're going to make enough hydrochloric acid to digest food. So GI, the most common gastrointestinal complaint is heartburn or acid indigestion. And the most common cause is GERD, gastroesophageal reflux disease. So you look right here, this is a normal esophagus. Here's your stomach, and this is leading to the small intestine. This is that sphincter. And notice right here, if your sphincter is not closing properly, you have acid coming back up. And your tissue, you do have a mucosal lining, but it's rich and enriched with nerve endings and very, very sensitive. So that's when you feel the acid indigestion or the discomfort. There's an upper and lower sphincter in the esophagus. So GERD results when either of the sphincters, and it's primarily this lower sphincter, does not work properly. Now here, let's talk about the H2 antagonists. They're a class of drugs that block the action of histamine 2 by antagonizing or blocking H2 receptors of the parietal cells. This decreases production of stomach acid. And remember, the proton pump inhibitors, where do they work? On the proton pump in the parietal cells. So H2 antagonists are indicated for the treatment of dyspepsia. Dyspepsia is just a big medical word for heartburn. Peptic ulcer. So that's when you have an ulcer that forms. You have a tear or a laceration in the protective mucosal lining. Anywhere the peptic means it's in the stomach. And duodenal means it's in the lower intestines. And then GERD, gastroesophageal reflux disease. There are 4 of them. All were originally prescription, but now every one of them is available over the counter. When they put them over the counter, they just put them in a strength that's 1/2 of the strength as the prescription. But you're going to notice they all end in tadine. So you got famotidine, ranitidine, nizatidine, cimetidine. Think of tadine like tadine. So if when you eat you have heartburn or discomfort, you're not going to want to eat. But if you take an H2 antagonist and it helps slow down the production or decrease the production of acid, then you're able to eat and not feel miserable. So tadine, think of tudine, and also the word 2 like TW0, it's a 2 antagonist. Then we got proton pump inhibitors. PPIs block acid production and proton pump activity of the parietal cells. It's indicated to treat, so at the very beginning, this is all the same as the H2 antagonist. Prevention of acid indigestion. For GERD, peptic ulcer disease. Now, peptic ulcer disease, this is inclusive of, there's multiple causes of ulcers in your digestive system. So you have an ulcer whenever you have a lesion. A lesion's like a cut. But when you have a cut in the digestive system and it's exposed to hydrochloric acid, it's going to erode and just rip and tear at that tissue and cause a lot of discomfort and a lot of damage. But they discovered something, and it was in the early 1990s. It was a pharmacist. He was a pharmacist that became a doctor, and then he went in and he earned a PhD in infectious disease. And he was also, he's the one that discovered that some ulcers in the stomach were attributed to H. pylori, a bacteria. So previously, it was just assumed when people had ulcers, it was because of stress or because of their diet, like alcohol, smoking. And then we've got Zollinger-Ellison syndrome. All of the proton pump inhibitors were originally prescription only. Now, all of them, with the exception of ones available as over-the-counter in lower strengths. And they end in Prazole, and there's more. Now, something else, this is something scandalous, and as you get more experience in pharmacy, it may affect you. Maybe you won't be bothered. But many of these drugs, they're called Me Too drugs. So the first one to come out was omeprazole, Prilosec. And then they had an exclusive patent. So whenever they discovered omeprazole, they apply for a new drug application. They're given 20 years patent exclusivity, but it takes about 10 years before the drug finally makes it to the market. Once it makes it to the market, they've only got 10 good years on their brand name exclusivity. After that, generics come out. Well, immediately, though, drug companies can be studying the molecular structure and playing with it to see if they can come up with something that's very similar, maybe works better, lasts longer, has some other property that's different or more desirable. And so one thing you'll see, we came out with pantoprazole, lansoprazole, rabeprazole. But where there's a scandal, one of the easiest things to do is to just simply move a molecule. Usually it's a methyl group, a CH3, and you just move it from one side of a molecule to another side. So we have SO and levo or dextro, dextro's right, levo's left, esomeprazole. All they did here was they just moved a methoxy group from one side of the molecule to the other. And so esomeprazole, when you take it, when it gets dissolved into a liquid, when it gets absorbed into the hepatic portal and goes through the liver, is converted to omeprazole. So it's not anything different, not anything special. Whenever Prilosec was prescription, it costs about $100 for 30 days worth. Then it goes over the counter and it's about $15 to $20 for 30 days worth. Nexium, it's about $200 for a month's worth. So why on earth would why would a doctor write for Nexium whenever it's virtually identical to Prilosec? Well, guess what? The company that makes Nexium, they were brilliant. They made contracts with hospitals. They made a contract. You know what? You You put Nexium on your formulary as your PPI, and we will sell it to you cheaper than the very cheapest generic you can find for any PPI. So the hospitals just nationwide adopted Nexium. If you went to a hospital and you needed anything for GERD, indigestion, you're going to get this purple capsule, a distinct purple capsule. And what happens when a patient leaves the hospital and they want to continue taking the medicine, they want to take what they used in the hospital, what worked for them. So when they leave the hospital, they're going to want to stay on Nexium. So it's kind of a scandalous reality of pharmacy practices. So of these, there's a couple of things to know. There's going to be 4 questions on your PTCE specific to unique drug dosage formulations. By that it means all these are available as an oral tablet or capsule. Some of them are available as a tablet that dissolves under the tongue. Only 2, the omeprazole and esomeprazole, are available by injection. That's something that's important to remember. And so in part, if you just remember Nexium, that's the one that's in the hospitals. And if you think about it, if there is an injectable form of a PPI, you would expect to have it in the hospital. So it'll help you remember. Pantoprazole, it's still prescription only. Now, what's interesting about pantoprazole, I've told you the story. They actually, Protonix, the brand name company, when they lost their exclusivity for generic, that their thinking was this: we're just going to open a generic company. We're going to make the generic. Since we're going to lose money to generics, we might as well own the generic company that's providing the product. So they created a company. They make the pantoprazole generic in the very same facility where they make the Protonix. And so in 2009, they accidentally sent out 4 million bottles of pantoprazole, 40 milligrams that contained 30 tablets. So pantoprazole generic. When you open the bottle and you look at a tablet, it actually had Protonix in red printed on the tablet. So they put the branded product inside the generic. But you're going to find there's many, many generics in a pharmacy that are actually produced in the same facility by the brand name manufacturer. Then Carafate. Carafate is a very unique, it's a one of a kind. We don't have anything like it. It's a drug that binds over the exposed ulcer by forming a chemical barrier. It's got a unique characteristic. It's attracted to enzymes that are released whenever you have a lesion in the digestive system, an ulcer. And so what it does, it turns into a gelatinous-like liquid, and it's attracted to the ulcer or the lesion, and it coats it. And it creates a paste-like barrier that binds. This barrier lasts 6 to 8 hours. And this barrier, it's almost like putting an occlusive dressing over a wound that you're wanting to heal. By covering it, by like placing this bandage over the wound, you're enabling the body a chance to heal on its own. It's very difficult for an ulcer to heal if it's just constantly being exposed to hydrochloric acid. But when you've got a covering, a coating. The thing with Carafate, though, it's a great big tablet, a giant tablet. A lot of times people have to break it in half, but it comes as a liquid, a suspension. The Carafate suspension is, it comes already mixed in pint bottles. It's stored at room temperature. So another aspect to the pharmacology questions on the PTCE has to do with where items are stored in a pharmacy. Many of the liquids that are suspensions, they have to be reconstituted and refrigerated. But there's an antibiotic, and I've told you this, guys, you'll hear it throughout the entire program. What antibiotic is a suspension, very commonly used in children. It's ready-made at room temperature, and that's sulfamethoxazole trimethoprim, or generic Bactrim. Another is generic Scepter. They're both just 2 different companies, those are brand names. But the question you'd be asked is, where's it stored? And people are inclined to want to put refrigerator, but it's not. It's at room temperature, so it's with your liquids. Same thing with Carafate suspension. It's a suspension that's just stored with your liquids in the pharmacy shelves. So what we're going to do, we're going to stop right here because the next section moves on to diarrhea and goes further. We're going to pick up on diarrhea tomorrow. So what I want you guys to do, if you have not finished watching the cardiovascular videos. I want you to watch the cardiovascular video. You have one assignment today, which is a 50-question open note quiz, and it's really just an assessment. It's more of an assessment. You're going to be able to find the answers. You can look in your book. It's not one from the Navigator Plus. This is one I created, and it more specifically relates to the kind of questions that you're going to be facing as a technician, or the kind of information that I would want you to know if we're working together, and I need you to assist me as best as a technician can assist. So you're going to find, I put it up to 45 minutes, but I think some of you are going to finish it much, much quicker. So it's listed in your course content assignment, and then you just click on that link. You guys remember, you enter your name. The passcode is always PIMA, all capital. When you complete it, take a photo of your high score and submit it to the assignment. Then with the remaining time, what time you have left, work on your drug cards. So the goal is to have 15 completed by Friday. So by Friday, you're going to have 27 completed. Our goal was 25. And so those extra 2, those I can use if you did not do so well on 1 or 2 cards. Well, then you've got these other 2 that I can consider. So last week y'all turned in 12. By Friday, you're going to have turned in 15, and you're going to still have plenty of time. 11 o'clock, Azalea, Jesus, and Kruti, you've got your Zoom session with Career Services. Everyone, you guys have a great afternoon. If anyone has a question, please email, message, text, or call, because tomorrow I'll pick up. We're going to have another Zoom session tomorrow, and we're going to finish the digestive system. We're also going to have a Zoom session in the morning. I'm going to go through the exercise y'all did today, but I'm going to introduce percentages. The percentages and calculations, initially, it's kind of confusing, but then once you work through a couple of them, it becomes fun, and you'll feel like an expert in no time. So everybody have a great afternoon. You guys are doing a wonderful, wonderful job, especially considering like nobody anticipated this being, distant education. It's been an incredible, fun, and interesting learning experience for us all. Okay, guys, and this is recorded. I'll put the link in your resource folder, and you just click on the link and you can watch any part of it in YouTube.